everyone. Welcome to our webinar series 2020. This is our talk 7. Today we are having Dr. Satish Kumar. He's a hematologist. He works in Columbia Asia Hospital in Bengaluru, and he's joining us directly from Bengaluru today. Welcome, Dr. Satish.
Thank you, Biswajit.
Good to have you here today. And before we get started with the talk, give us a little background about yourself, where you're from, and what kind of work you do. Dr. Satish has done his post-graduation, I think, from KEM Mumbai. Is that right, Satish? Yeah.
And he did MD I did from KMC Manipal. DM
right.
in clinical hematology I did from KEM Mumbai. You're right.
Right. Yes. Yes. Yeah, he was actually one of the toppers in Manipal, if I'm not wrong. Yeah. And he did his fellowship from Canada. So before you get started, Satish, a little bit about yourself, where you're from, and the background about your work, and then get started with the talk, okay?
Sure, Baruwa. Thank you.
Right.
Thank you so much, friends. At the outset, I'd like to thank Dr. Biswajit Baruwa and KIMS Oman for giving me this opportunity. It's an honor to be talking in front of you all. So as Biswajit mentioned, I did my MD in general medicine from KMC Manipal, and then I did my training in clinical hematology, which we call in DM in India, from KEM Mumbai. After that, I did a fellowship in leukemia and bone marrow transplant from Vancouver, Canada. And once I came back to India since 2008, I've been at Columbia Asia Hospital. There are a group of hospitals present in Southeast Asia. In Bangalore, we have 4 Columbia Asia hospitals. I'm mainly attached to Yeshwanthpur Columbia Asia Hospital. I do go to other hospitals once a week. So at Yeshwanthpur, I was fortunate enough to have a very good team of oncologists, and myself being hematologist, we have formed a team of hematologists and oncologists. And we do treat both benign and malignant hematology. And transplant is what we are very interested. So we do autologous and allogenic bone marrow transplant at Columbia Asia, Bangalore. So it's almost 12 years now I'm associated with Columbia Asia Hospital, and it's going good. Thank you.
Excellent. Fantastic. So we'll get started with the presentation.
Yeah, thank you. And I'm so sorry for the glitch. So I'll be talking on the role of newer oral anticoagulants in venous thromboembolism. So I've kept it very simple because there's a mixed audience. You can interrupt me whenever possible or at the end of the presentation.
Satish, we'll take the questions at the, we'll take the questions at the end of the presentation. You can finish we'll keep a note.
Okay. All right, great. So I'll start with a simple case we all encounter in our usual practice. 35-year-old female presented with proximal DVT in the left lower limb. And the most important thing we need to take in the history, whether it's provoked or unprovoked. Unprovoked in the sense she does not have any history of immobilization. She has not met with an accident. She was not on oral contraceptive pills. She is not pregnant. So she's just working lady, and she just developed the swelling of the limb. And when they did a Doppler, they detected an unprovoked DVT in the left lower limb. So in such a lady who is educated, who has access to internet, what is the best option for management of the DVT? Let us look at the options. We have several options. Our age-old friends, heparin, unfractionated heparin, low molecular heparin, and vitamin K antagonist, coumadin group, porphyrin, acetron. And we have our new friends, direct thrombin inhibitors, dabigatran, factor-10 inhibitors like rivaroxaban, apixaban, edoxaban, and the list goes on. So coming back, so the options for anticoagulation are the old heparin versus and the coumadin group versus the newer drugs, newer oral anticoagulants. So what additional information is required if we have to prefer the newer oral anticoagulant? So my aim of this presentation is, at the end of the presentation, we should understand which patients are good candidates for these newer drugs, which patients should not be started on these newer drugs, how should the newer drugs be initiated, what all is the checklist to be seen before starting these newer drugs, how do we monitor the patients on these newer oral anticoagulants before starting and on treatment, are there any interactions with diet or drugs, how do we manage if patients on these newer anticoagulants have any bleeding manifestations, or God forbid they develop any accident and they come for surgery, perioperative management, and how do we follow up? What is the frequency of follow up? So this is the aim of my presentation. So let us look at the history and how these anticoagulants were developed. Quite interesting that the heparin was almost discovered in 1916, but the therapeutic use was started only in 36. Similarly, coumadin group or warfarin was discovered in 1940. Basically, it was used more as a rodenticide. And then in 1950s, they started using clinically warfarin. The mechanism was, however, discovered in 70s. Low mercury heparin was discovered in 1976. For the next 25 to 30 years, we did not have any drugs except for heparin and warfarin. In 2000, they started doing clinical trials on pentasaccharide like fondaparinux. And from 2010, it has been very interesting. We have so many newer oral anticoagulants which have changed the landscape of treatment of venous thromboembolism. Let us first sort out these names. What are antithrombotics? Antithrombotics include both antiplatelet agents like ecosprin and clopidogrel, and also anticoagulants. Anticoagulants, as I mentioned earlier, can be heparins, can be newer oral anticoagulants. There are a lot of names, and you will encounter different names even in my presentation for these newer or novel anticoagulants. So NOAC means newer or novel oral anticoagulant. It also means non-vitamin K oral anticoagulant, target-specific oral anticoagulant, direct oral anticoagulant, are all the acronyms for these newer oral anticoagulants, which includes both factor Xa inhibitors and thrombin inhibitors. So how do they act? If you remember our physiology, we have an intrinsic and extrinsic pathway. Both of them converge, and the final, the molecule which is formed because of the, either if it is cellular pathway or the age-old intrinsic extrinsic pathway, it is thrombin, which cleaves fibrinogen to fibrin. Thrombin is present in fluid phase and also in clot-attached form. This is inhibited by dabigatran or direct thrombin inhibitor. The advantage of dabigatran over heparin, which also inhibits thrombin, is that heparin inhibits only fluid phase or circulating thrombin, whereas dabigatran inhibits both clot-bound and fluid phase thrombin. One step before that, where the intrinsic and extrinsic pathway converge, is factor 10. So there is a 10ase which is formed, which is inhibited by this factor 10A inhibitors. 10A is the active form of 10, which is inhibited by the 10A inhibitors, which are rivaroxaban, apixaban, edoxaban, betrixaban, and many more are in line. One molecule of factor 10A almost leads to formation of thousands of molecules of thrombin. So you can imagine how potent these 10A inhibitors should be. So what are the advantages of these newer oral anticoagulants over vitamin K antagonists? The most important is that these newer oral anticoagulants have a predictable pharmacokinetics and pharmacodynamics. The half-life is short and they have a rapid onset of action. So the action starts immediately. So for conditions like DVT, sometimes we don't need to give a bridging of heparin. We can directly start with these drugs like rivaroxaban. They also have a short offset. That means once we stop the drug, the effect, because of the short half-life, the effect goes away very fast. For example, if someone presents with bleeding or if someone is planned for a procedure, compared to warfarin, the offset of these neuro anticoagulants is short. The dosing is fixed. This is the biggest advantage compared to warfarin, where we need to go on checking the INR and monitor the dose. Here, the dosing is fairly fixed across a certain weight. There is no diet interactions. Again, the biggest advantage with the newer oral anticoagulants. Whereas warfarin, because it depends, it acts as a vitamin K antagonist. The effect of warfarin will depend on the amount of vitamin K produced in the liver, amount of vitamin K which we take in the food, and also cytokines in the liver. So there's a lot of diet effect and drug interactions, too many drug interactions with warfarin. Any patient with warfarin, if you're starting a drug, you have to Google and see what is the interaction. Will it decrease the INR? Will it increase the INR? With NOACs, there are very few interactions which I'll discuss. And the most biggest advantage is there is no need to monitor the effect of newer oral anticoagulants because they have an improved safety profile. There is no routine monitoring. They have a wide therapeutic window. Whereas with warfarin, the therapeutic window is very narrow. So you have to keep the INR between 2 to 3. We need to monitor it. All of us have seen several times the INR will be well maintained for several months and suddenly it takes off or it goes down. So we have to continuously monitor INR with warfarin, whereas with NOACs, there is no need of routine monitoring. So these are all the advantages of newer oral anticoagulants. Are there any disadvantages? Yes, there are disadvantages. In the trials, they have shown that these drugs are very safe and effective, but you need to understand that trials always are ideal situation. They don't take children, they don't take patients who are planned for surgery, and the trial, this thing is completely different compared to what we see in real life. So the disadvantages are mainly in India. I'm sure in Oman also, the cost of the newer oral anticoagulants is quite significant compared to age-old warfarin. The dosing varies for each drug. I discussed about 4 drugs. You will see in the future slides that you cannot be familiar with only one drug. It is better if you know one drug and use it, but you may have a patient who has been started on other drug. The dosing is completely different for each drug, and the indication for atrial fibrillation is different, for prophylaxis it's different, for treatment it's different. So we need to remember all these dosings and indications. And if the patient has renal insufficiency or liver problem, again the dosing will be different. Antidote, I cannot say is not available now, but it is not easily available. It's quite expensive. It is not easily available. Even in Bangalore, where I work, there are only 1 or 2 centers which keep the antidotes for these newer oral anticoagulants. Whereas for warfarin, vitamin K is available in each and nook and corner of the country. Compliance, because we don't monitor, we have to rely on the patient. There is no way to test the compliance. For warfarin, we know if the INR is in therapeutic range, the patient is compliant. Whereas here, we cannot we have to just rely on the patient, what he says, because we don't monitor. That's a double-edged sword. There are few drug interactions, but they are important and we need to remember them. We cannot just dispose saying it does not interact with any drug. And it is not approved in all indications. Warfarin can be given in all the indications wherever therapeutic anticoagulation is required, of course, except for pregnancy. For example, mechanical heart valve. As of now, newer oral anticoagulants should not be used on patients on mechanical heart valves. Aplar syndrome. They have shown in several trials in Aplar syndrome and some thrombophilic conditions, the incidence of thrombosis is significantly high compared to warfarin for some unknown reasons. When we compare warfarin and newer oral anticoagulants, the incidence of thrombotic events or rebound thrombosis is higher with this NOACs. So universally, they have said newer oral anticoagulants are contraindicated in Aplar syndrome. They should not, there is no data still in children, and they're contraindicated in pregnant and lactating mothers. So we should understand that it's not approved in all indications. There are some specific adverse effects we need to remember. For example, in the trials, they've seen that GI bleeding, dyspepsia is slightly higher with dabigatran compared to the other newer oral anticoagulants. So we need to remember when we start a newer oral anticoagulant, there are some contraindications and we should know the disadvantages too. Coming to the comparison between these warfarin and vitamin K antagonist and newer oral anticoagulants, this is just in broad comparison. The common things are all these newer oral anticoagulants have the time to peak effect is very short. The half-life is short compared to warfarin. All of them have renal clearance compared to warfarin, which does not have renal clearance. This says that if someone has severe renal impairment, it is safe to use warfarin compared to newer oral anticoagulants. No need for monitoring for any of this. And as I said, there are some drug-to-drug interactions. So as I said, before starting newer oral anticoagulants for any drug, a thorough evaluation should be conducted to ensure that the patient is a good candidate for this therapy. There should not be any contraindications. We should look at organ function, like we have to do a KFT, kidney function, liver function, make sure the kidney function is appropriate. A baseline CBC, prothrombin time, APTT should be done. concomitant drug therapies should be looked at to avoid any significant interactions. Look at any contraindications. If the patient is admitted with pulmonary embolism and is potentially maybe planned for thrombolysis, better not to start newer oral anticoagulant, better to start with low molecular heparin. Wait only if the patient is not a candidate for any surgery or intervention, then only you start them. Understand the risk of bleeding. And the most important thing is we need to give importance to patient preferences and willingness to take this newer oral anticoagulant. They should be highly likely to be adherent to the newer oral anticoagulant. We need to counsel them. I'll discuss what all we need to counsel the patient before starting the newer oral anticoagulant. And as you see, consider the unique characteristics of each of these newer oral anticoagulants when deciding which drug to be used. If you see, there are some drugs like rivaroxaban and apixaban. You don't need any bridging with heparin. You can directly start the treatment. But if you see, again, the dosing is different initially. For example, with rivaroxaban, the first 21 days, this is for proven DVT. You need to give 15 milligrams twice daily for 3 weeks, followed by 20 milligrams OD. For apixaban, it is 10 milligrams BD for 7 days, followed by 5 milligrams twice daily. Whereas for dabigatran and edoxaban, all the trials have given a lead-in therapy with low molecular heparin for 5 days, followed by the drug. So we need to remember which drugs require a lead-in therapy, which drugs we can directly start the drug. And also you can see these doses will differ based on the creatinine clearance, especially when you're using it elderly patients or people who are diabetic.
Satish,
coming to the monitoring, yes.
Satish, sorry to interrupt you. The thing is a little less. So what you can do is you can see that on the right-hand corner of your screen, no, there's one 85%. You can increase that to 100%. The slide will be a little larger for everyone to see. Yeah. Yeah.
Okay.
Excellent. Okay, go ahead.
Sorry, Sorry, I don't know why the full PowerPoint is not working.
No, webinars are like that.
No issues at all.
Okay, yeah. Go ahead. Yeah.
So coming to the monitoring of these newer oral anticoagulants, because of their specificity, predictability, wide therapeutic index, fixed dosing, there is no need for routine monitoring. But yes, there are scenarios when monitoring is required, especially if the patient on a standard dose without any issues comes with bleeding, unexpected bleeding, or if they're planned for an urgent procedure, they met with a road traffic accident, they have to undergo surgery for fracture. So these are the scenarios when we have to see whether any clinically relevant levels, drug levels are present. Can we take the patient for surgery? Or if they have a rebound thrombosis, that the patient is quite compliant, taking the correct dose of the drug, and he develops a thrombosis on treatment. So we need to see whether they have expected on therapy levels, why they have developed this thrombosis. So those are scenarios we need to see. And of course, in renal insufficiency, whether there is any excessive levels. So one indication is to see clinically relevant levels before undergoing an emergency procedure. Second thing is to see whether their expected on therapy levels, if they develop a thrombosis, or detection of excessive levels if they have a bleeding or if they have renal insufficiency, etc. So what are the methods of monitoring the patient? Unfortunately, the usual PT, APTT, platelet count will not help in monitoring the NOAC. For dabigatran, the most sensitive assay is heparin clotting time. I know it's not easily available. It's not available even in our hospital. If I send heparin clotting time, there is one lab which does it. I get the report only in 1 day, but that will be too late. So the next best blood test is dilute thrombin time or thrombin time. So that is a sensitive indicator for dabigatran. If that is also not available, then we can just do a plain APTT. APTT will not tell exactly the level or the function of dabigatran, but one thing is, if the APTT is normal, it excludes any excess drug dabigatran levels. For example, the patient has taken a tablet the previous day and you have to do a surgery today, emergency. If the APTT is normal, patient is on dabigatran. If the APTT is normal, then we can safely go with the surgery because a normal APTT excludes any significant dabigatran levels. For rivaroxaban, apixaban, edoxaban, we have to do factor 10A assay, which is specific for the drug. So we have factor 10A assays for low molecular heparin also. That is not the ideal thing. The lab has to do it specifically for it has to be calibrated for the specific anticoagulant. If the lab cannot do calibration, then you can use the heparin factor 10A assay only. It is not validated, but that can substitute it. PTA, PTT, unfortunately, are not reliable for these factor 10A inhibitors, but there's some data saying, again, similar to APTT for dabigatran, if the PT is normal on factor 10A inhibitors, it rules out any significant drug level. So this is the way we need to monitor it when someone comes with an unexpected bleeding and or plan for procedure. What do we do when they require temporary interruption of these drugs? So for example, some patients require some procedure. At least 10% of the patients on anticoagulation require temporary interruption annually. Normally with warfarin, what we do is we stop the drug. If they've just completed 3 to 4 months of anticoagulation, we give bridging low molecular heparin or unfractionated heparin, then stop it after 12 to 24 hours before the procedure, do the procedure, and then restart the low molecular heparin, overlap with warfarin. Once INR comes, we stop the heparin. That is what we do with warfarin. Whereas with neuro-oral anticoagulants, the bridging therapy can be avoided unless and until it is a acute DVT in the first month. If you're doing something, we require bridging. But most scenarios, we avoid bridging therapy with heparin on these neuro-oral anticoagulant patients. You can safely stop it, and we can do the procedure after, I'll tell you, after 4 to 5 half-lives of the drug is over. Preferably delay the procedure if it's a mild dental extraction, minor procedure, delay it as much as possible until the patient completes the course of neuro-oral anticoagulant. Minor procedures, we need not interrupt, like endoscopy and things like that, we need not interrupt. For any significant procedure, we have to consider 3 things. One is the bleeding risk of the procedure. Second is the renal function and the half-life of the drug. These 3 things have to be taken into account while stopping the drug. So simple rule is, for any major surgery, we should give at least 5 half-life time should be given to eliminate more than 95% of drug concentration. This is not only for neuro-oral anticoagulant. Any drug, once 5 half-lives are over, almost 95% of the drug is not there in the body. So because most of the drugs have a half-life of 12 to 14 hours, so 12 into 5, 60. So if you give a gap of 2 to 3 days, most of the drug is over. So for any, usually I say the creatinine is reasonably normal for these neuro-oral anticoagulants. If it is a mild to moderate bleeding risk surgery, we can wait for 2 days after stopping the drug. If it is a major surgery, neurosurgery, I prefer to stop it for 3 days, or the 3 days after stopping the tablet, we can take him for surgery. If it is an emergency procedure, like a fracture, as I said, time of the last injection should be noted. Rapidly assess the residual anticoagulant effect by doing a thrombin time for dabigatran. If it is possible, factor 10A assay for the neuro-oral anticoagulant. Increased risk of bleeding should be weighed against urgency of procedure. Sometimes we cannot wait for 5 half-lives. At that time, we have to weigh what is more important. Is the risk of bleeding more, or is the procedure important, and take an individualized decision. And we need to remember that post-procedure, we should restart the anticoagulation. If it is a low-risk bleed, start the tablet 24 hours post-surgery. If it is a high-risk procedure like neurosurgery, start the tablet 48 to 72 hours after the procedure. I would prefer after the surgery, you bridge with heparin, because sometimes there may be rebleeding and things. Better to keep on heparin and mechanical prophylaxis. And once we are sure there is no risk of bleeding, we can restart the oral anticoagulants. If they're having ongoing epidural anesthesia, it is better to avoid the neuro-oral anticoagulants. If the patient is in ICU and has an RT and you have to give something through the nasogastric tube, do not give dabigatran, because dabigatran cannot be crushed. It loses its effect. Only rivaroxaban can be given through a nasogastric tube. But such situations, I would generally prefer low molecular heparin only. Coming to the drug interactions, as I said, there are very few interactions with the neuro-oral anticoagulants. With strong P-glycoprotein inducers and inhibitors, avoid concomitant use of in fact, all the drugs or P-glycoprotein substrates, dabigatran, edoxaban, rivaroxaban, apixaban should be avoided if you're using strong inhibitors or inducers of P-glycoprotein. Rivaroxaban and apixaban, apart from P-glycoprotein, it is metabolized by cytochrome system. So combined strong inducers and inhibitors of P-glycoprotein and cytochrome P450 should be avoided along with rivaroxaban or apixaban, or if they have to be used, better to choose other drugs or monitor the level if you're using rivaroxaban, because there might be a significant interaction between these drugs, especially if you're using combined strong inducer and inhibitor of P-glycoprotein and cytochrome P415. What about the usual NSAIDs, ecospirin? They're saying that if you use antiplatelet agents or NSAIDs along with this neuro anticoagulant, there is a significant risk of increased major bleeding in all the trials. So preferably avoid usage until benefit judges the bleeding risk. Suppose the patient has had angioplasty, stent is there, you have to use an antiplatelet agent. You need to explain the patient. I would prefer in such cases warfarin plus ecospirin. But if it's impossible to give warfarin, ecospirin is safe enough. Giving clopidogrel or newer antiplatelet agents, we have seen quite a significant increased risk of bleeding. You have to counsel the patient regarding the disadvantages. How about transition between one anticoagulant to another anticoagulant? Why should we switch? See, annually 4 to 6% of warfarin patients switch to this neuro-oral anticoagulant. Usually they are switched when there is a therapeutic failure. Suppose someone on warfarin develops a thrombosis in spite of therapeutic INR. Then we switch from warfarin to this neuro-oral anticoagulant. Or if they have drug intolerance, or the patient expresses a preference to take this neuro-oral anticoagulant. Vice versa also, if the patient is on neuro-oral anticoagulant and they want to switch to warfarin because of the cost issues, we should know how to do this. I'll not go into the details, but it is mentioned there are guidelines. You cannot just like that stop warfarin and shift to neuro-oral anticoagulant. There are guidelines how to go about it, whether it is warfarin to neuro-oral anticoagulant, heparin to neuro-oral anticoagulant, and vice versa while switching from neuro-oral anticoagulant to warfarin. So these are available on the net, freely available. If anyone has a specific doubt, they can mail me or ask me at the end. How about if some patient develops bleeding on neuro-oral anticoagulant? So as soon as someone on anticoagulation and develop excessive bleeding comes to the emergency room, we should find out which anticoagulant the patient is on, when was the last dose ingested, is he on any antiplatelet agent, is there a kidney problem? So after answering all these questions, we need to, if the patient is on dabigatran, as I said, check APTT and thrombin time. If the APTT is normal, it almost rules out any significant level. If they are prolonged and if the patient is having significant bleeding, for any of the drugs, most important is stop all the antiplatelet and anticoagulation, the usual management to manage hemostasis, give tranexamic acid, except for hematuria, you can give for all bleeding manifestations, activated charcoal, if the dose is taken within the last 2-3 hours. For dabigatran is removed by hemodialysis. That is one more advantage of dabigatran. Or by dialysis, you can remove the excessive levels. In spite of that, if the patient is bleeding, you have an antidote for dabigatran, which we called as idursulizumab, which is a monoclonal antibody which targets mainly dabigatran. And similarly for rivaroxaban, we have andinestat alpha. For other drugs like apixaban and edoxaban, we have to give prothrombin complexes if it is available. And general measures, there is no antidote for apixaban or edoxaban. Once the patient is started an oral anticoagulant, we have to follow them up once in 3 to 6 months. We have to check the creatinine, liver function, discuss with the patient about any upcoming invasive procedures, whether they have been started on any new drugs which may potentially interact with this, and whether they develop newer contraindications, like if there is a young lady, if she's becoming pregnant, or if she wants to conceive, better to shift to a different oral anticoagulant. Counseling is the most important thing on neuro-oral anticoagulants. You have to activate the patients and caregivers. You have to educate them about the disease and the medication. You need to tell them what is the indication for starting this drug, what are the precautions taken, what is the importance of the timing of the drug. They cannot take one day morning, one day evening, or if they're taking twice daily, it's very important to maintain the timing. If they miss a dose, what needs to be done? If they develop bleeding, what are the simple things? Suppose a lady has menorrhagia or has little excessive bleeding, how she can manage at home, when should she report to us? And it always should be done in appropriate literacy level in the patient's preferred language. The teach back method is very important, which I follow, where I tell the patient to tell back to me what she has understood and what all she has understood about the drug, so that we know how much she has followed, and give a document, proper document, what is the indication for anticoagulation, what is the intended duration of therapy, what is the dose and scheduled time of administration. All these things have to be mentioned. I even mentioned the warning signs, when to report back to us, to the patient. All this should be written in the discharge summary or in the document provided. There's a very nice article in Journal of Thrombosis and Thrombolysis in 2016. Most of the things what I've discussed is mentioned there. The guidance for the practical management of direct oral anticoagulants. If someone is interested, they can go through it. So to conclude, these drugs are they're significant advances. They're very convenient, likely safer than the conventional therapy. Though they represent a significant advance in venous thromboembolism, there is complexity of the dosing regimens, which we have to be, as clinicians, aware of all the regimens, contraindications. There is variable effects on the common available coagulation assays. We should know when to do them. And most important thing is effective patient education, which I feel is the cornerstone, which will help to manage the patient and safely on these newer oral anticoagulants. We need to understand, when we manage anticoagulation, both efficacy and safety are important, and imbalance in any of them can result in patient harm. So I end with that. I think I've taken more than 30 minutes, Satish. So if there are any questions, I think it's better to have time for the questions. Yeah, I hope my presentation was audible at least. I am sorry for the glitch in the screen sharing.
No, it was audible. Some people had, I think, bandwidth issues, so they were not able to hear, but it's okay. We heard you and we saw it. Excellent presentation. Let me just maximize your screen so that they can see you as you answer the questions. Okay. A couple of questions are coming in. So I will start the question with this. The concern for surgeons, especially with the anticoagulation, is the question about bleeding, wound healing issues and all. So the usual studies that are done to determine which one is efficacious. Now, what are the parameters they usually take to assess how efficacious this particular drug is? For example, say rivaroxaban. If somebody is doing a study on rivaroxaban, what are the parameters they usually take to say this is efficacious?
So most of the trials, what they have done, for whether it is for prophylaxis or treatment of thromboembolism, they look at thrombosis incidence. So most of the trials, if you see, they will say that rivaroxaban is non-inferior to warfarin in terms of efficacy, by saying that the number of thrombotic events in warfarin were this much, on rivaroxaban were this much. So if the number is almost similar, they say that rivaroxaban is non-inferior to warfarin. So they're all non-inferiority trials. They also look at the number of bleeding events and grade 1, grade 2, grade 3, grade 4 bleeding. And they have seen these newer drugs are safer compared to warfarin. The incidence of intracranial hemorrhage was lesser in these newer oral anticoagulants compared to warfarin.
Yeah, the reason I asked this is because the anti-coagulation guidelines for surgical patients as well is set by usually the American College of Chest Physicians, ACCP. And the American Academy of Orthopedic Surgeons has been very vociferous of late, raising concern about the dosages, saying that bleeding has not been taken into account, wound healing has not been taken into account. And so they are suggesting other things as well. But I think you made it quite clear that it's necessary and it has to be done. There's one question by Dr. Sara. She's a pathologist, and she's asking, when do you decide to use unfractionated heparin or low molecular weight heparin? And when heparin is a choice, what is the difference between the both? I think she's trying to understand the difference between heparin and unfractionated heparin. And tell us a little bit about when is your choice for this and when is the choice for the other one?
Yeah, no, very good question, Dr. Sara. So initially, I mean, during our training itself, during MBBS, MD times, we used to always do unfractionated heparin when someone develops a DVT. So the nuances with unfractionated heparin is monitoring is very difficult. You need to keep the APTT, titrate it, follow the nomogram. It's very difficult. So gradually, we have shifted from unfractionated heparin to low molecular heparin, which is a fixed dose based on the weight of the patient. So there is no need to monitor. So I would prefer low molecular heparin over unfractionated heparin when the patient has an acute DVT or if the patient has an acute PE and they may be taken up for thrombolysis or something or planned for a procedure, I would prefer low molecular heparin to unfractionated heparin. Is there any indication at all where we can prefer unfractionated heparin? Yes, if the patient has severe renal insufficiency, low molecular heparin is contraindicated if the creatinine clearance, especially is less than 30 or less than 15. It is better to avoid low molecular heparin. And suppose the patient on renal failure, on hemodialysis, comes with acute DVT, I would prefer unfractionated heparin. That is the only scenario where I prefer unfractionated heparin to low molecular heparin. The other reason is the cost. If they cannot afford low molecular heparin, suppose say a pregnant who requires heparin prophylaxis due to APLA syndrome or bad obstetric history throughout the pregnancy, again I would prefer low molecular heparin. But if it is expensive, then I prefer unfractionated heparin. So by guidelines, the indication for unfractionated heparin is when the patient has renal failure and acute DVT.
Thank you, Satish. Also, this newer anticoagulants, direct anticoagulants, TSOAC, that's a lot of names actually. Is this a name confusion, or are we becoming more clearer regarding what kind of anticoagulants?
Yeah, I think it is both, Biswajit. It is both. So there are so many acronyms, unfortunately, target specific, newer oral anticoagulant, novel oral anticoagulants, non-vitamin K, they all describe the same. It's all acronyms for the same drug.
Right. So these oral forms are mostly the newer anticoagulants. Is that right?
Yeah.
The rivaroxaban and those, right? Just to be
that
clear for everyone.
Yeah.
Yes.
Yeah.
Okay. There's also a question by Dr. Manjeet. He's our anesthetist. He's telling a very good presentation, appreciating your presentation, and saying, new anticoagulants, do they need to be stopped when inserting or removal of epidural catheter? Say, for example,
yes,
if
Dr. Manjeet.
Yes, go ahead.
Yes. So I avoid completely these neuro anticoagulants when we are using epidural. If the patient is going for epidural, definitely we should not start or stop. I mean, if someone is on and you have to start it, at least wait for 2 days, 48 hours, 5 half-lives of the drug, and then you insert a catheter. Similarly, while removing the pump, I would suggest to stop for 48 hours at least and remove it. There are risks of spinal hematomas. We have seen a patient who developed a spinal hematoma and developed paraparesis. Patient was managed outside in Gujarat, where they developed paraparesis and landed up here. Unfortunately, they had removed the epidural catheter on rivaroxaban without the patient had not reported or something. So we have to be very careful. I completely avoid these agents. That is why post-op, I would prefer low molecular heparin as long as the patient is on epidural catheter, because we know how many hours to stop. If the patient is on prophylactic dose, you can stop for 12 to 24 hours and remove the epidural catheter. Whereas with this neural anticoagulants, it's quite a nuisance, especially if the creatinine is high, we need to wait for longer. So avoid neural anticoagulants for patients where epidural is considered.
Yeah, so post-surgery in that scenario, what you mean is that if the patient is already on rivaroxaban, obviously we have to stop, wait for the appropriate time, 5 half-lives, as you said, and then do the planned procedure. And for procedures like, for example, hip replacement, where we normally use some kind of low molecular weight heparin, and then have the epidural removed, and then make the switch over to the rivaroxaban oral.
Yes. After the epidural is removed, I think ASRA guidelines say 12 to 24 hours later, you are safe to start the neuro anticoagulant. There is American Society of Regional Anesthesia. They have specifically mentioned 12 to 24 hours after the removal, you can start the neuro anticoagulant.
Right, and he says, he also mentions second part. Second part he's written, throughout the time, can we keep the epidural catheter? That doesn't make sense, yeah? Because epidural catheters cannot be there forever. They have to be removed. And
they have to be removed.
They should not be on this rivaroxaban at the time of removal.
No, what he's asking is, if suppose it requires a presence for a long time and the patient is on anticoagulation, I mean, people have been on low molecular heparin prophylaxis with epidural catheter. Only when you try to remove it, you stop it. So it's the same situation if you're asking for neuro-oral anticoagulants. I would not prefer, Dr. Manjeet, for the patient to be on neuro-oral anticoagulants during this time. But if suppose someone has started prophylactic dose and the patient is having an ongoing epidural anesthesia, only when you plan to remove it, you stop it at least again 4 to 5 hour half-life before removing the catheter. If someone has already started it without your knowledge and you have to decide now how to remove the catheter, you stop it for 4 to 5 half-lives and then remove the catheter. Yes. It's okay. I mean, if someone has started prophylactic dose and they're having ongoing epidural, that's fine. It should not be removed before the 4 to 5 half-life of stopping the drug.
Excellent. Thank you. There are a lot of questions coming in. Dr. Shashiraj, he's internal medicine and he's our medical director. He says, very good presentation. He's asking, can we use newer drugs for DVT prophylaxis? So, yes. So a little bit about, prophylaxis and therapeutic. Is there a difference? And
yes. So the biggest difficulty with these drugs is we need to know the dosing. So I would request all the clinicians to be familiar with one drug. Let them have a knowledge about the other drugs, but you can prefer one drug and know all the dosing guidelines. For example, rivaroxaban or dabigatran, whichever is available. One drug you can take it and know the prophylactic doses in, suppose, a TKR or hip replacement. The dosing is slightly different, so we have to know the doses. Even for prophylaxis, it is found to be both efficacious and safer compared to warfarin or giving low molecular heparin for longer time. In fact, all the trials with this newer anticoagulants started as prophylaxis after replacement, hip replacement or knee replacement surgeries, and then they started testing in the initial indications also was approved as prophylaxis, and then they were tested in trials in the management of DVT. So they can be used in prophylaxis. The dosing is different. For example, dabigatran, you need to give 110 milligrams twice daily, whereas the treatment dose is 150 milligrams twice daily. For rivaroxaban, the prophylaxis dose is 10 milligrams once daily, whereas the treatment is 20 milligrams once daily. So we have to know the dosing differences. And even this dose differs with creatinine clearance if the patient is elderly. And one more thing I want to emphasize is if someone is more than 70, 75 years, we prefer apixaban. It has been shown it is relatively safer compared to rivaroxaban and dabigatran. So apixaban, I would prefer in elderly patients more than 75 years, even if because the metabolism of apixaban by the kidney is the least compared to the other two drugs. If they have mild impaired renal function, prefer apixaban. So apixaban as prophylaxis, I think the dose is 2.5 milligrams twice daily, whereas for treatment is 5 milligrams twice daily. So doses are different. You can definitely give even after knee replacement. In fact, life is very easy when we give for some indications, we give it for 35 days. These newer anticoagulants are a boon for those patients.
Absolutely. I think that way oral anticoagulants make compliance very easy, actually.
Easy, correct.
Yeah. Just tell us, rivaroxaban is Xarelto, apixaban and dabigatran. Can you tell us the commercial names?
Pradaxa. Dabigatran is Pradaxa.
Okay.
Apixaban, I'm not aware. I don't use it much. Right. I can just tell you it's a Pfizer product. Sorry, Eliquis. Eliquis is apixaban. Eliquis.
Yes. Okay. Yes. Okay, just to be clear, there's so many names now and so many drugs now. We need to be a little clearer.
So I'll just summarize. Xarelto is rivaroxaban. Yeah. Pradaxa is dabigatran. Yeah. Eliquis is apixaban.
Excellent. Great. Dr. Abu Bakr, he's asking, those who come to ER with ACS, we load them with clopidogrel and aspirin. As you told, the risk of bleeding with antiplatelet is high. Is this case, is there any specific measurement that you can do?
No, unfortunately, Dr. Abu Bakr, that is always a problem. Patients who are on newer anticoagulants, when they develop an ACS, it has happened that they have been loaded with an aspirin and clopidogrel, which we do for all patients. We have seen some excessive bleeding like intracranial hemorrhage and things. The incidence is slightly higher in such patients, but there is no specific guidelines because we cannot say avoid loading with clopidogrel or aspirin in such patients. So as far as I'm aware, there is no specific guidelines for patients on these neuro anticoagulants when they present with ACS. So as of now, we are also doing the same thing. We are just telling them to be careful. Hopefully, they have taken it one day before we tell them to avoid the next dosage of the neuro anticoagulant unless until it's deemed necessary. We tell them to avoid the further doses of neuro anticoagulant. And maybe if someone has atrial fibrillation, we can just start heparin after, if it is deemed necessary, low molecular heparin once you load them with antiplatelet agent.
Okay, excellent. Thank you, Dr. Praveen, who's our cardiologist, and Dima, clinical pharmacist. They said Eliquis, just as we were discussing.
Eliquis.
Yeah. Anyway, yes, I think we got that. Dr. Praveen, like I said, our cardiologist, he's asking any use of FFPs in management of bleeding risk when patient is on DOAC and needs early surgery. Will FFP help?
No, Dr. Praveen. Unfortunately, FFP, cryo, platelets are of no help for any of these anticoagulants. Unfortunately, this is of no help. If you can get access to prothrombin complex concentrate, they might help. Again, PCC or APCC, activated prothrombin complex concentrate, are not easily available. I'm not sure in Muscat in India, it's very difficult to get our hands on them. So it is very difficult. There is no point in giving FFP or cryo at all for these patients. It's not going to help at all.
Right. Okay. Dr. Abu Bakr has got one more question. What about PCI and thrombolysis in these cases with ACS, the ones you were talking about, clopidogrel aspirin combination? What about, he says, what about PCI and thrombolysis in this case?
The same thing holds good, Dr. Praveen, the Abu Bakr, sorry, that thrombolysis can be done, but it is quite risky when they are completely therapeutically anticoagulated with this newer oral anticoagulant, because the risk of intracranial bleeding is found to be slightly high. But patients, we have in our practical experience, when it is deemed necessary, they have gone ahead with thrombolysis, and most of them have luckily have not had any issue so far. So we can go ahead with thrombolysis when it is indicated, because if someone presents with a major arterial block and you have to do thrombolysis, I think we can go ahead. But you need to explain the family that the incidence of serious life-threatening bleeding, for example, intracranial hemorrhage, is slightly excessive because patient is already on therapeutic anticoagulation. We are overloaded with antiplatelets and we are going for thrombolysis. But when it's indicated, we have to go ahead.
Yeah, it depends upon the situation. If it's necessary,
exactly. Yeah, if we can, yeah, yes, we have to individualize. Of course, we have to individualize. If it can wait for at least 24 hours, 12 hours, then better to do it as an elective surgery, elective procedure. But if it is deemed necessary, we have to individualize, explain the risks and benefits to the patient, family, and go ahead. I agree.
Yeah, since we are talking about this aspirin, now aspirin has been used also as especially for patients on post hip replacement, knee replacement. We are using low dose aspirin. Little bit about aspirin and how does it act?
Aspirin is an antiplatelet agent. We can use it as a prophylaxis for arterial or treatment for arterial thrombi. For DVT prophylaxis, aspirin alone may not be sufficient, Biswajit. So I would not prefer aspirin alone after hip replacement or knee replacement. Once you stop the prophylaxis with anticoagulants, whether it's newer or oral or whatever older ones, once you stop it, if you want some agent to just make sure the blood does not clot, aspirin may be of help, but alone as for VTE prophylaxis, it's not indicated. Aspirin is not the preferred drug for thromboembolism prophylaxis, especially after replacement surgeries. Aspirin alone may not help.
Yeah, this is an area of a lot of controversy actually, because the AOS is really pushing hard for aspirin, taking into account saying that the studies that are looking at the efficacy of these NOACs are mainly looking at incidence of DVT, whether it is clinical or subclinical. But what the AOS is saying is that no, you should be looking at only clinical DVTs and not subclinical DVTs. Things like that. But of course, this is an area of debate and a lot of discussion can be done on
Correct.
this. Yeah.
No, I agree. Newer data may come up saying that aspirin alone may be sufficient, but evidence, as you said, like ACCP guidelines, if you take, they would not suggest definitely aspirin alone as a agent for DVT prophylaxis. See, I have done that for patients with unprovoked thrombosis. Once you give 6 months, 1 year, then you evaluate for thrombophilia. If they do not have any thrombophilic condition, the patient asks, should I really continue? If you see the ACCP guidelines, they say for any unprovoked thrombosis, patient is a candidate for lifelong anticoagulation irrespective of the thrombophilia. But it's not easy. I mean, for the patient to tell them that you have to take a lifelong anticoagulation, they're very keen to stop it. So at such circumstances, I have stopped the anticoagulation after the intended duration and switch them to aspirin, just hoping that it might decrease the incidence of VTE or it can act as a prophylaxis against VTE. But alone, I mean, for post-surgery patients, I'm still not convinced, or the evidence is not very clear that ecosprin alone will be enough for at least the 1 month or 2 months. But as you said, it is a controversial topic.
Right. Okay. And the same line, Dr. Shashiraj, our medical director, is asking for patients with DVT after treatment for 6 months, how do we decide whether to continue treatment or not?
Sorry, 1 second. So after 6 months, I usually evaluate the patient, and first thing I do is, suppose if when someone has a DVT and I decide in my mind this patient requires 6 months of anticoagulation. After 6 months, I do a D-dimer and see if the D-dimer has become completely normal. I also do a Doppler or a CTPA, whatever. Usually if they have a DVT, you said, so we do a Doppler and see if the vein is completely canalized. Sometimes it may be partially canalized, decanalized. Sometimes it can be just a chronic thrombosis. But if the D-dimer is negative, we are safe to stop the therapeutic anticoagulation. After 1 week or 2 weeks, depending on what we have used, I evaluate the patient if they have any thrombophilic condition, if there is any tendency to thrombose again, like the usual hereditary thrombophilia profile, we go ahead and do. And if anything comes positive, for example, the patient has Apla syndrome, which is an acquired thrombophilic condition, then I need to counsel the patient that you need to take lifelong anticoagulation. Or if the patient has a family history of thrombosis and he has protein C or protein S deficiency, we have to again call the patient and say that they need to take lifelong anticoagulation. If all the thrombophilia workup, both acquired and hereditary thrombophilia workup comes negative, I counsel the patient. If that is the first episode of DVT, I counsel the patient in detail and then stop the anticoagulation. Tell them that the risk, because it's an if it's a provoked thrombosis, there is no doubt 6 months enough thrombophilia workup. There's no need for any other counseling. But if it's an unprovoked thrombosis, I counsel the patient that there is a risk that it can happen again. If it happens second time unprovoked, you have to take lifelong anticoagulation if it doesn't have any thrombophilic condition. I hope this helps.
Right. Okay. Dr. Praveen, cardiologist, dose of Pradaxa in therapy of DVT or AF, the dose you use is 150 milligram BD or 110 milligram BD?
In treatment of DVT, it is 150 BD. Even in AF, it is 150 BD. Elderly patient, 110 BD.
Right. Okay.
Elderly patient with atrial fibrillation, 110 BD is the recommended dose.
Right. Okay. Excellent. So Dr. Sibasis, he's our bariatric surgeon. He's got a big comment. Let me just read it out. Many times post-op cases, as per American chest guidelines, we are supposed to start DVT prophylaxis, but we encounter hematoma, etc. Should we make a hospital-based guideline not to follow American guidelines?
No, that is very good question. Always we prefer to have hospital-based guidelines and make it very clear. We should not blindly follow some protocols. That is always better. We have our own protocols when to give prophylaxis. We keep the ACCP guidelines as a template and we modify it to according to our hospital users. And you have to individuals, Dr. Sarah. If the patient is having hematoma, you can't just go on giving a therapeutic or whatever prophylactic anticoagulation. We have to wait for some time and then start. Until that time, because if it is a bariatric surgery especially, you have to at least follow mechanical thromboprophylaxis, DVT pumps and things like that. And if the patient is oozing or bleeding or a big hematoma, you have to individualize the care. You can't just blindly follow the guidelines. Even in ICU, I keep telling my ICU colleagues, as soon as the patient shifted to ICU, they start injection enoxaparin 40 milligrams supplements daily. I say you have to individualize the patient. You need to look at the parameters. Please wait for the lab, see whether the patient is at risk of bleeding, and then only start it. So you have to individualize the patient. And it's always better to have hospital-based guidelines for such patients.
Excellent. Yeah, excellent. That was Dr. Sibasis, not Dr. Sara. And obviously, yes, and obviously, like all prophylaxis does not have to be chemical. Like you said, it can be mechanical. For example, hip replacement patients, we emphasize on getting them out of bed as quickly as possible. We hydrate them well.
Correct.
All these measures are also equally important, so that if you have hematoma and bleeding, you can fall back on these other mechanisms as well.
Yes, Biswajit, those are very important points. What you said: adequate hydration, fast mobilization, very fast mobilization, and DVT pumps or stockings. All these things are very, very important. It helps in such patients where you are worried about therapeutic or pharmacological thromboprophylaxis.
Right, Dr. Manjeet, our anesthetist, has got one more question. Sometimes patients come for life-saving emergency surgery. They don't have any idea of anticoagulant drugs they are taking. What do you suggest should be our monitoring test?
So at least a normal prothrombin time, APTT, platelet count, if they're all normal, I think you can safely go ahead. and I just ask, I mean, this is outside the purview of anticoagulation. I just ask them if they've undergone any surgery or tooth extraction recently, if it is uneventful, if there is no excessive or delayed bleeding. And these parameters, history is very important. If they are not forthcoming, they don't know the drug, what the patient is taking, then at least look at the screening parameters, which is platelet count, prothrombin time, and activated partial thromboplastin time. If these three are normal, we're almost safe to go ahead.
Excellent. Yeah, that's important. History gives a good indication of how has been
the hemostasis.
Yes, yes. Yeah. Excellent. Very good. Thank you, Satish, for taking those questions. Just give us a little overview of how this pandemic has affected your work. Are you still going to the hospital to see patients?
I think it's the same universally, Barua. We have made teams in our hospital. So we are 4 of us in hematology oncology. We have made a team A and team B. So I'm covering alternate days. Me and my colleagues, we go on alternate days like Monday, Wednesday, Friday. The other team covers Tuesday, Thursday, and Saturday. So we just attend the emergency inpatient referral, and we have shifted to teleconsult completely for follow-up patients. Only when it is deemed necessary, we call them to the OPD. As much as possible, we have shifted to all teleconsults for follow-up patients. Patients are also appreciating it because of the lockdown. They are also finding it difficult to come. So they're very happy with teleconsults. So hardly 1 or 2 outpatient, new outpatients. Inpatients also have decreased significantly. So we just see there are a couple of acute leukemia patients undergoing chemotherapy. We just say hi to them, and half day we wind up and come back. So the uncertainty is killing us more than anything. We are not sure when this is going to end, but this is the way we are doing it.
Right. Okay. Excellent. In related to that, D-dimer levels are very high in these COVID-19 patients. So are they predisposed, or meaning would they need some prophylaxis or treatment with anticoagulants?
Yeah. Yes, see, they've looked at a lot of data. Unfortunately, a lot of data has come up from China only. And there is one study from Netherlands also, which has come up that patients with COVID, especially I'm talking about those serious patients who are admitted in the hospital, especially in the ICU, and they've seen that these patients have a higher risk of thrombosis. So initially, ISTH recommended around in March, they recommended that patients with COVID pneumonia admitted in the hospital, if they have a higher D-dimer, when they say higher D-dimer, 2 to 3 times the upper limit of normal, then better to start low molecular heparin prophylaxis. But now they've changed the guidelines. I can pass it on to you, Biswajit. They have said any patient with COVID, if he needs admission to the hospital, whether it is ICU, whether it is ward, start them on low molecular heparin prophylaxis. If they don't have any contraindication, like platelet count is not very low, or if they're not bleeding, better to start thromboprophylaxis for all COVID patients admitted to the hospital, whether in the ward, whether in the ICU, better to start low molecular heparin prophylaxis. In fact, for selective patients, they suggest to even increase the dose of low molecular heparin prophylaxis, like 40 milligrams BD, 30 milligrams BD, but that still evidence has to come. As of now, any patient with COVID admitted to the hospital, better to start thromboprophylaxis if they do not have any contraindication.
When you say admitted to hospital, meaning that they are a little serious and they are needing treatment in the hospital?
Because the incidence is unfortunately, the incidence is quite high. DVT is very high. In one study from Netherlands, very disturbing that even though the patients were on thromboprophylaxis, they're seeing DVTs. So, and they are recommending that some group of patients might require higher dose of prophylaxis, but still that recommendation has not come in, Biswajit. They have suggested ISTH, that is International Society of Thrombosis and Hemostasis, looking at it. As of now, any patient admitted to the hospital with COVID-19 or suspicious of COVID, better to start low molecular heparin prophylaxis, which is enoxaparin 40 milligrams subcutaneously once daily.
Excellent. Yeah. This is a fluctuating situation, and a lot of things are fluctuating. Obviously, it will take a while before we come to conclusions exactly. Everybody has been very appreciative of your talk, Dr. Satish, and Dr. Praveen says, thank you for an elaborate presentation. Dr. Manjit says, thanks. Dima, clinical pharmacist, she didn't ask any question, but anyway, she says, very interesting presentation. Thank you a lot. Thanks, Satish, for making it today to the webinar. We are grateful to you for having been with us. Any last comments or words you have for us?
No, thank you so much, Bariva. It was my privilege. It was my honor. I'm so happy to see a lot of questions being asked. And I'll share my email ID with Dr. Biswajit. Any doubts, you're welcome. If he has my number, you can WhatsApp to me, you can email to me. If any practical questions, any doubts on these newer anticoagulants or on thromboprophylaxis in COVID, I can send you the latest guidelines. And I'm very, very happy for having shared my knowledge and having interacted with you all. Thank you so much.
Thank you. Thank you so much. All right. So we'll call it a day for today. And for the rest of you, we have our next webinar on Monday, and we have Dr. Smita. She's going to be talking to us. Thank you all. Thank you, Satish. Goodbye.